All right, so we got three conditions to look at today. We're going to be looking at hypertension, coronary artery disease or coronary heart disease, and peripheral arterial disease. So all of these are definitely going to be like blood vessel dysfunctions, very much related to athero and arteriosclerosis, right? So very common amongst our senior clients, atherosclerosis and stuff. It's usually caused by like dyslipidemia, or we called it hyperlipidemia, I think, at the beginning of this class. But it's basically often caused by like too much cholesterol building up on the inside of our blood vessels. But it can also be caused by stress or hormonal dysfunction, not getting enough sleep. Lots of different things can kind of cause excessive salt intake. A lot of stuff can cause like that hypertension and those, hard arteries. So we're going to be looking at sort of what it means to kind of train somebody who's dealing with that, because like obviously it can have pretty drastic implications on the amount of exercise somebody is able to partake in. So first looking at hypertension as like a definition, right? So hypertension, more commonly known as like high blood pressure, is a condition in which an individual's blood pressure is at least 140/90. So you'll see some other terms out there. Ideally, our normal blood pressure will be somewhere around 120/80. Pre-hypertension is going to be somewhere around 130/85. But then like actual like high blood pressure, very dangerous, chronically 140/90. Now, again, you guys have heard me, I kind of brought this up last time we talked about blood pressure. They've taken like blood pressure while someone's like doing like a deadlift before, and the number has been up over 300. Like it's not that you can't elevate your blood pressure. And sometimes when people go in to get their blood pressure tested, doctor won't have them sit long enough. There's a lot of different things that can kind of happen and sort of interrupt those numbers. But ideally, we want it to be chronically somewhere around 120/80. That's the sort of perfect amount of pressure inside of our blood vessels, right? And just to give you an idea of what those numbers mean, by the way, when I say it's 120/80, the 120 number is representing how much pressure is in your arteries when your heart is contracting. So we call that systole. That's your systolic blood pressure. And so like when your heart squeezes, obviously blood's going to go rushing through your arteries. And so the amount of pressure pushing on the walls is going to be higher. But then as the heart relaxes, and that makes more space in the heart, and blood goes rushing in there, which lowers your blood pressure, the amount of pressure pushing on those walls is closer to about 80. So 120/80 is what we're looking for there. And that's millimeters of mercury, technically, is what the MM stands for. But anyway, ideally, right, we want it to be, somewhere around here. If we see our client, regularly, like something like this, that's showing that, they may be on the road to hypertension. And once they start dealing with hypertension, there's going to be a lot of like health risks there, right? I didn't realize I actually did put it in the notes. So systolic blood pressure, right? Pressure on the vessels during systole. It's the amount of pressure during the heart's contraction, because blood is being ejected from the heart, which raises the pressure. And then diastolic, which is diastole, that's the pressure, during the heart's relaxation. So what the heck? How the heck do we, why does our blood pressure get screwed up? What's going on there on a physiologic level? Well, particularly big risk factors tend to be diets that are high in fat, particularly saturated fat. When you look at the difference between like saturated and unsaturated fat, they literally look different on a visual level. Like on a chemical level, here's the difference. You can actually see a saturated fat has this like long straight line here. Picture like a table with a bunch of chairs and all of the chairs are filled. So that's a saturated fat. All the chairs are saturated, right? Versus like what we see over here, there's like a kind of a kink in the table, right? There's sort of this double bond in the middle. And so it creates this kind of interesting shape here. That is an unsaturated fat. So saturated fats, because they are these long straight lines, they can stack really easily. If you take a bunch of molecules like that and put them near each other, they can stack into something that's relatively solid, you know, versus like this version here. If you were to stack all those molecules next to each other, they wouldn't stack very well. There'd be little gaps in their structure. There'd be little empty spaces. Those little empty spaces are going to make the fat, instead of looking like a solid, it'll actually look like a liquid whenever it's at room temperature. So this is where you can actually see that in the real world when you look at the difference between saturated and unsaturated fats. I don't want to pick good fat versus bad fat. I don't like that. Come on, internet. There we go. Nah, I don't like that either. Hold on. There we go. That's what I like. Okay, so here's a good picture of saturated versus unsaturated, right? You can see the saturated stuff on the left are things like meats, cheeses, even a little bit of fish there. So see the white, the white fat along the meat there, right? The fat cap, that is saturated fat, and it is a solid, right? Like even though this is at room temperature right now, this is relatively solid, right? Butter is a really good example of a saturated fat. It's relatively solid even at room temperature. I mean, obviously, it gets kind of soft, and that's actually because there is a lot of unsaturated fat in butter as well. But over here, we can see like very much like the oil that you're going to find in like nuts and stuff, that, how they kind of have that oily texture, or like how fish is, salmon is actually going to have saturated and unsaturated. That's why it's in both pictures. But that salmon, that fish right there is also very oily, right? And then obviously there's straight up olive oil, right? That is very much unsaturated fat. So saturated fat is a solid at room temperature, and unsaturated fat is liquid at room temperature. So now that you start thinking about that, it's like, oh, well, that darn stuff could be a solid inside my freaking blood vessels, like, and that's one of the things that's going to cause it to clog, and why it's very important for us to have a very balanced diet of, plenty of unsaturated fat along with any of the saturated fat that we do occasionally get. I'm not like, here's the thing, like saturated fat is considered a bad fat, but it is not as bad as we've sort of given it credit for. I think that like it actually has some benefits. It's just that we've done it like everything else in the world, where we just live in a version of the world where we get way too much saturated fat. And now we're sort of overreacting and being like, you can never have any saturated fat, which honestly, if you do take that approach and then you live, you try to limit your saturated fat, well, guess what? You might actually end up landing where you're supposed to in the long run, considering that, like, people usually tend to eat out and stuff. But ideally, your saturated fat intake should be about 10% or less of your caloric intake per day. So if you're on a 2,000 calorie diet, you want about 200 calories of saturated fat at the most. So diets high in saturated fat definitely lead to hypertension, because again, they're going to build up that blood vessel plaque, right? We're going to see that material, just that cholesterol, kind of build up inside of our blood vessels there, and then eventually that's going to cause, red blood cells to get clumped up, and that's going to increase the pressure. So definitely something we are trying to avoid. Smoking, another really big one, right? Smoking can literally harden your arteries. It actually is basically putting like certain types of chemicals into your bloodstream. Like when you think about like how your lungs work, right? So your lungs are these little like empty sacs. Your lungs kind of end in these little sacs like this, right? So it goes down and it branches and branches and smaller and smaller and smaller until eventually it looks like this. There's little like tubes at the end with these little popcorn shapes here. And if you were to cut them open, they would look like this. They're these little like, little holes. And they are absolutely covered, as you can see, in blood vessels, right? Like look at all these blood vessels here. So one of the best ways to get something into your bloodstream is to inhale it through your lungs. So if you're bringing in all kinds of like materials and chemicals that you're going to get from like cigarettes, those things are going to get directly into your bloodstream. And yeah, we always talk about like the negative effects of smoking when it comes to like the lungs, right? Like we're constantly like, you're going to put this gunk in your lungs and then it's going to be stuck there. And, when that happens, you're going to, eventually have a hard time breathing because your lungs are filled with crap. You know what I mean? But the thing is, like, we don't spend enough time talking about the negative effects of like how it affects our blood vessels. All of those chemicals that do make their way into our bloodstream are actually going to lead to like high blood pressure and coronary artery disease and all kinds of like other problems, which is even worse, right? Like now we've got another thing to kind of worry about with smoking. So it's definitely something we are trying to avoid. And then excessive body weight is a big risk factor. Like I said yesterday, we do know that like, excessive body fat is dangerous in general, but in particular, abdominal fat has been shown to be even more dangerous in particular. And so that is definitely something we want to keep an eye on. When you think about like having all that abdominal fat, it's going to interrupt your body's ability to sort of deliver materials, right? That adipose tissue is there, and it has its own metabolism, and so blood needs to like get supplied to that to keep those cells alive. And so now it's like, okay, well, we've only got so much blood to kind of move around. We've only got so many blood vessels, right? We're gonna start doing it. And then if we do break down that abdominal fat for energy, it's saturated fat, that is the type of fat that you're going to find inside of our body. So it's sort of a roundabout thing. So when all that happens, right? So those are sort of the three main causes. Obviously, like hormonal dysfunction could be another one. Like if you're just consistently stressed in life, that is going to release like cortisol, which is going to harden your arteries. That's also really bad. But what are some of the health risks? Like, if we know that why is high blood pressure so bad for us, right? So aside from saturated fat, smoking, excessive body weight, and stress, what are some of the negative effects of high blood pressure? Well, one of them is going to be chronic heart failure. Your heart may not receive enough oxygen due to the fact that you have like limited blood flow. And if that happens, then your heart's not going to be able to function properly. We're about to get down here and we're going to look at coronary artery disease, which is literally going to be where like this happens right here. This sort of plaque buildup thing happens, but it doesn't just happen in any old blood vessel. It happens in the blood vessels that supply your heart with blood. So coronary artery disease is the most dangerous version of this hypertension problem. It can be very bad elsewhere as well, but like in particular, if you are blocking any of these blood vessels that surround the outside of the heart, your heart is just like any other tissue. I know that like it kind of seems like you're like, well, isn't the heart going to get plenty of oxygen delivery since there's just going to be blood inside the chambers of the heart as it is? Like that would make sense, right? But your heart actually doesn't absorb oxygen and nutrients that way just because blood happens to be traveling through the heart. It needs to have blood vessels covering the outside tissue the same way the rest of your body does. So what it does is it has its coronary arteries, which you can see are these red tubes here. Actually, here's a really good picture of a little bit bigger for me. So if you take a look right here, you can actually see this little tube right here. That is your aorta. That's the main sort of chamber, or that's the main sort of tube that comes out of the heart. When your heart squeezes, it rushes out the aorta, and then some of it goes up here, goes up to your brain. Some of it loops around the heart and drops down and goes to like your organs and then the rest of your body, right? But you'll notice the first stop, the first branch of this artery, before even the ones that go up to your brain, circle right off and come straight back to the heart itself. So it's like, if you've ever been on a plane and they're like, secure your own mask before, securing the mask of another, your heart supplies itself with blood before it supplies any other tissues in the body with blood. So if you block that, well, now the pump, which is designed to send blood throughout the rest of the body, can no longer function because the cells are dying because they're suffocating. And that's coronary artery disease. So very, very, very dangerous. That can lead, this is why hypertension can lead to chronic heart failure. It can also lead to stroke. Let's say the exact same thing happens, but now instead, we've got this, these main, there we go, that's a great picture. You can see like, this is your carotid artery, right? And so like, blood cannot travel and get up to the brain, and your brain cells are neurons, which require massive amounts of oxygen. So now if your brain can't get enough oxygen, we're going to deal with sort of a stroke, right? The brain can't get enough delivered, and that leads to cell death. And then one of the other things associated with high blood pressure that we don't really think about all that often is kidney failure. High pressure on your kidneys. So you got to remember that like your kidneys are your filters, right? All of your blood and lymph and things like that, like all that material runs through your kidneys because it's where we filter stuff out, and so if you are running, super high pressure through this all the time, it can actually damage that kidney. It can actually be basically like blasting it with, think of I picture like a pressure washer right on the inside of my kidneys. Like there's so much pressure coming out there, I'm like stripping the paint off my house, like or stripping the paint off the outside of one of your dad's trucks when you were 14, which is something that happened to me. So got to be careful with pressure washers. Those things are intense. That's kind of what it's like inside your kidneys, right? So it definitely leads to damage there. So those are some of the risks associated with blood pressure. That's why it's so bad for us. But the good news, fun stuff, is that like exercise has a really positive effect on blood pressure almost immediately. It's one of the fastest positive effects that we have. So particularly endurance training has been shown to reduce blood pressure by an average of about 5 to 7 sort of millimeters of mercury, sort of 5 to 7 units there. So if you were at like 135 over 85 or something like that, this can have like a really positive effect in just a little bit of time. And so what we know about like exercise, right, is that exercise is not only going to improve like, how well you function, like you're training your heart by elevating your heart rate slowly, and like now your heart's like, oh man, like we have to function, we have to like, work, right? And anytime that we work something in the body, what happens? It gets stronger in order to be better at working, right? So you will actually see an increased vasodilation response in response to exercise. So what vasodilation is just basically a fancy way of saying it's your blood vessels opening up. So it's your blood vessels dilating, right? That's vasodilation. So when you exercise, one of the physiologic ways that remember when we talked about the autonomic versus peripheral, or the autonomic versus the somatic nervous system, right? So your somatic system is the stuff that you have control over, and your autonomic system is the stuff you don't. So your body will prioritize blood flow to wherever it needs it most, because you only have so much blood in your body. So when you start exercising, your body will prioritize blood flow to your muscles. And then when you stop exercising, your body will prioritize blood flow to your digestive system. This is why we have that sympathetic versus our parasympathetic nervous system. The sympathetic one is known as fight or flight. The parasympathetic one is known as rest and digest. So this is what's kind of cool about that. And let's just, and actually we'll take it even one step further. So then if that's what happens, right, when you start exercising, it goes to your muscles. When you stop exercising, it goes to your organs, right? But now let's say what about like if we want to get even more specific, let's say I want to send blood flow to just my upper body. Well, we're going to send blood flow to the upper body by vasodilating the upper body and vasoconstricting in some capacity the lower body. And that's going to direct blood flow to wherever it is needed most, right? So this is why like exercise has been so good for vasodilation. It actually trains your blood vessels. You think about lifting weights, it's about doing a bunch of reps, right? Well, opening and closing blood vessels is kind of like doing little reps inside your vascular system, which is pretty great, you know. So we know that that's going to give us increased kidney function. That's going to decrease our stress hormones by lowering, burning up those hormones and using them. And then we're also going to increase our insulin sensitivity. Remember, we talked about how blood sugar, if there's a lot of sugar inside your blood, that's also going to raise your pressure in some capacities, right? There's just more stuff in the system. By exercising regularly, you're going to be burning off carbohydrates for fuel. And when that happens, when you burn those carbohydrates off for fuel, what ends up happening is that your body goes, great, well, we're going to use that, we're going to use those carbs. And next time I bring in carbohydrates, I've got space to store them rather than having to convert them into body fat. So endurance exercises also has a really positive effect there. And so again, like diabetes and hypertension, all these diseases associated with obesity start to disappear when we start to exercise more regularly and be physically active. Love that. So now, what are some of the rules? How the heck do we do this in a practical way? So it's like, okay, we know that high blood pressure is bad for us, and we know why it happens, and now we know how to sort of fix it with general exercise. What about the specifics? What are some of the specific things that we can do as trainers to have a positive effect here? How do we do this? Well, special considerations for hypertensive clients. One, make sure your client is seated or standing because you want to avoid either prone or supine positions. You don't want to lay your client down face up, and you don't want to lay them down face down. That sounds a little bit weird because it's not like they're dealing with pregnancy like we talked about yesterday. It's not like they're dealing with anything like that. So why the heck can't we bring their head down and bring their head up? Like, what's so wrong with that? Well, remember, they have a blood pressure problem, right? And like I've said before, you guys have probably had that thing where if you've ever stood up too quickly and then you try to go somewhere and then your brain's like, ooh, and you get a little like lightheaded for a second. That is because all of the blood, that's a very sudden, very dramatic drop in blood pressure. Because like your blood pressure was really low because you were sitting around, like you weren't really doing anything. So your body's like, well, this is easy, and it's on easy street, right? But then all of a sudden you get super excited because door rang or something, you got to get up, you're like, and then your body was like, oh, we did not have like constriction in one place and dilation in another in order to move blood to where it needs to go. We're kind of all just relaxed right now. So what ended up happening is you moved and your blood kind of just stayed in one spot. It basically like probably flooded to your legs. So then your brain doesn't have enough oxygen, or at least doesn't get enough blood flow, and then it thinks it's not going to get enough oxygen soon. And as a protective mechanism, it is sort of designed to make you pass out because it's a lot easier for blood to travel horizontally than it is to have it travel vertically. So if your brain goes, whoop, we're having pressure problems, lay down, it's just kind of a protective physiologic function there. So we want to avoid that. If we have a client with blood pressure problems, it's not that you can't lay them down. It's just that you don't want to lay them down and then put them back up and then lay them down and put them back up. Like burpees, if you are changing the orientation of their head too fast, your client might get lightheaded. They might feel like they're going to pass out. Burpees is a big, big, big no-no with clients who have hypertension problems because, your head goes from being this way to being this way to being this way to being this way. Ball crunch, or really just crunches, sit-ups is a kind of a no-no, right? Blood in the head. And that's how I want you guys to think about this. Like with a pregnant client, we're basically not laying them face down or face up because we're not trying to put too much, we're not trying to affect blood flow to the fetus or whatever, right? We're trying to like keep them in like a neutral position. With a hypertensive client, the reason we're doing this is a little bit different. You can lay them down. You just want to make sure if you do, you're probably doing a lot of laying down things in a row. And then like you can bring them up, give them a second, they'll normalize their pressure and then move on to the rest of your workout. Put all your, face upright stuff in a row. But do not, do not, don't just don't change the orientation of their head too quickly. It's very similar to dealing with a client with vertigo. So vertigo is not in the book because it's not very common. But vertigo is a condition of the inner ear, actually. And what it is this little, like, you have little stones inside your ear. I know it sounds really weird, but you get these like little rocks that kind of float along this like fluid that's on the inside canal of your ear. And basically they act to tell your brain like what is upright. Because, you know, if you tilt this way, then all the fluid rushes this way, right? It honestly is just like the little bubble in a level. You know, like, you know, you're hanging like a picture or something and you're like trying to make sure it's level. That is really, really similar to how these little stones work. And so they allow your brain to kind of understand what is up and what is down. In vertigo, usually somebody will take like a hit to the head, or they'll like get really bad cabin pressure on like a flight or something, or they'll get like an ear infection, and something will mess up the orientation of those stones. So their brain will have a really hard time understanding what is up and what is down, and they'll get really dizzy really quickly. So very similar to our hypertension clients, you basically just want to keep them kind of their head in one orientation all the time. Does that make sense, guys?
Yes, sir.
Cool. Mir, I saw you unmute. I went, haha, there you get the
This guy.
thumbs up. I love it. All right. So what else are we looking at? So when it comes to your stretching, it says static and active stretching is going to be allowed. Now I put a little asterisk here. This is me talking. I do want to point one thing out that I have read multiple times over the years. So static stretching is an isometric. Static stretching is something where you hold in one position, right? Isometrics in general should be avoided for clients who have hypertension, because it actually raises the pressure in your system. So like one of the things we're going to see is we're also going to modify our tempo. Our lifting tempo is going to go 4-1-1 instead of 4-2-1 like we've seen previously. So we're actually just going to never take a pause when we're lifting. We can move nice and slow, but we don't want to have big, long pauses. So planks are also pretty inappropriate for clients with hypertension. Wall sits are definitely something we're avoiding for clients with hypertension. Anything where they're basically holding in one position, that's the kind of stuff we're trying to avoid. So I've read a lot of stuff that says that static stretches are kind of part of that. So like big, long 30-second hold stretches, not really recommended for clients with hypertension. Instead, you can do active stretches, right? Stretch for about 2 seconds and then let the tension off 2 seconds and then relax, right? Like that's going to be a little bit of a better option in my opinion. However, it doesn't actually say that in this book. So, and then SMR is not recommended. We don't want to do that because we're already having blood pressure problems. We don't want to pinch any of those vessels closed. Cardio training, typically we are going to focus on stage 1 only. So we're really not going to take their heart rate any higher than about 75% of their heart rate max. So we want our client, if they're doing cardio, to be somewhere between 65 and 75. We think about the Tug Test, that should be somebody who can hold a conversation comfortably the whole time. Or if we think of that on the RPE scale, we would say that's like a 6 on the RPE scale, maybe a 7 at the most, on the sort of 1 to 10 scale, or we call that like a 13 to 14 on the sort of traditional RPE scale. But basically we want to keep it really low. And the reason for that is because we actually know that endurance exercise, stuff that they can do for an extended period of time, is going to be what's most effective, rather than like sprints, which are incredible for other reasons, right? We love high intensity interval training, but it doesn't, because it's so intense, you can't do it for very long. And we want a long duration exercise for someone with hypertension. So we're going for endurance here. I love a good 5K, you know, I love like a good 100-meter dash, but they are just, we're focused more on a marathon, you know. So phases 1 and 2 of the OPT are going to be suggested because, again, those are our low intensity, sort of gentle phases of the OPT. And then one of the coolest things we're going to do is what is known as a peripheral heart action system is suggested. So what a peripheral heart action system is, you guys may have done this on your own before without really realizing it. But let's say I'm going to pick a leg and shoulder day, right? Let's say I'm going to put a leg and shoulder day together. So if I decided to do that, right, we'll say example A. So let's say I'm going to do like, we'll start with the shoulders. We'll go with like a military press. And then I'm going to do maybe like a lateral raise. And then I'm going to do, let's say like a reverse fly. And then let's say like a barbell squat, deadlift, hip thrust. Okay, so let's say that's like what we're going to do as a general circuit, right? So if I did this as a circuit, which would be pretty friggin' challenging, right? You know, it's going to be like 3 shoulder exercises in a row. I mean, there are definitely different parts of the shoulder, you know, one's sort of anterior, one's lateral, one's posterior, right? So we can see like that's not so bad. You know, this is mainly like glutes and quads. This is glutes and hamstrings, and this is just glutes by itself, which actually is kind of a lot. But, you know, let's say that that's how I want to do my circuit. It's not bad, right? Sending blood flow from top to bottom. I don't hate that. I don't think it's necessarily bad. But one thing that we know is really effective for clients with hypertension, if we're trying to repair it, is doing a peripheral heart action. So this is typical vertical loading. Shoot. And this over here is peripheral heart action. So what we're going to do is we are just going to arrange this where we are going to go upper body, and then we are going to go lower body. And then we're going to go back to upper body, and then we're going to go down to lower body. So what that does is now your body has no choice but to take the blood high. Let's sneeze, hold on. And then to send it low, right? High and then low and then high and then low. It has to kind of go back and forth and back and forth. So if we think about like exercise is basically reps for your blood vessels, this is a really good example of that, right? All of a sudden you're doing a military press and blood vessels to your upper body open up and the blood vessels to your legs constrict. And then you go do a barbell squat and now your blood vessels to your legs are going to open up and your upper body is going to constrict. So you are doing dilation and constriction repetitions with your blood vessels. And that's called a peripheral heart action circuit, or PHA circuit. I like this for pretty much any client that I've got. I love a good peripheral heart action circuit. It's a great way to build endurance. It's challenging. I wouldn't necessarily keep it super. This is kind of a simplified version where I was like literally just chest and or literally just shoulders and legs. In the real world, I'd probably do, you know, maybe like a chest exercise, like a standing cable chest press, and then go with like a goblet squat. And then go with like standing cable row. And then I don't want to change the orientation of their head, so deadlift was not actually a super awesome option. Go with like a step up to balance. Let's go with standing dumbbell shoulder press, and then go with like a walking lunge. Let's go with bicep curls, and then we'll go with like a calf press, and then tricep extension. And there we go, right? Every one of those exercises keeps the body upright, so their head really never has to change orientation. But I went from here to here to here, back down to here, up to here, back down to here, 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 and here, here, and here, right? Like up, down, up, down, up, down, up, down. And that's a really good program for someone with hypertension. Then I just got to look at my sets and reps, right? So what are some of our other rules? So we like a peripheral hard action circuit training that involves alternating between upper body and lower body. And you can see here's a really similar workout to the one we just built, just minus the arms. And then we also want to avoid any isometric tempos, right? So we really like 4-1-1. So that's like a really slow, like eccentric for 1, 2, 3, 4, 1, 1, 1, 2, 3, 4, 1, 1, rather than like a 2-second pause in any position. Or we really like 2-0-2, which is just that even, sort of neutral, normal tempo that you think of. Or even 1-1-1 actually wouldn't be bad either, Also, super heavy lifting is probably going to need to be avoided just because they can't necessarily do that Valsalva maneuver. Because they can't do that. We don't want them to ever hold their breath. And if they do, that's going to raise their pressure. And then we also want them to avoid over gripping. One thing you also want to be cautious of with hypertensive clients is they will sometimes, like the deadlift again is actually just not a super terrific exercise for a client like this, because they may just like grip the bar like crazy, and that's going to cause blood to pool. And again, that's going to raise pressure. So we're just basically avoiding anything where they're really, really, really holding one specific position. So our mode, we are going to try to work large muscle groups. We're going to focus primarily on aerobic activities. And so, large muscle aerobic activities are great. We love the treadmill. We love the rowing machine. Anything where they're not necessarily pausing. I will say swimming is great. However, it should be a little bit cautious just because of like blood, not blood flow, but like, breathing and stuff can sometimes be challenging. Frequency, pretty much every day of the week if you can get somebody moving. This is the type of thing where like if I've got a client who really does have like high blood pressure problems, I'm trying to get them as active as possible. If I can get them on like a 4-day workout routine, like 4-day lifting routine, and have them do like dedicated cardio on Tuesdays and Thursdays, or Wednesdays and Saturdays, and then go for like maybe a gentle hike on Sundays, like, that gives them plenty of recovery time. It's not doing too much work, and it really does kind of evenly distribute things throughout the week. Intensity, you're going to go 40 to 60% VO2 max. Again, that's going to be pretty much zone 1. That corresponds to about 60 to about 75% heart rate max is where you're going to see that. So that's sort of what's recommended there. Your duration, you'll notice this is greater than 30 minutes of continuous physical activity per day. So this is where you guys have heard me say, if you've got a client who doesn't have the endurance, they can't handle sustained bouts of exercise, you can do like 10-minute bouts, maybe 3 times a day or 4 times a day. And that can total up the number of minutes. That's great for a caloric burn. It's not necessarily bad. But in particular, hypertension, what is going to be effective is greater than 30 minutes, like endurance style duration exercise. I don't think you necessarily need to go like 90 minutes. That's kind of crazy, but like a good 60-minute workout, that's where we're aiming. And if it's on their off days, if they get like 5 days a week of 60 minutes, or if they're lifting and doing like some cardio for like 60 minutes, Monday, Tuesday, Thursday, Friday, and they want to do like 30-minute cardio sessions on like, that's actually fine. But we do want to get them around up to that 30 minutes at least. In terms of mobility assessments, pushing, pulling, overhead squat, single leg balance, single leg squat, all that's fine. Flexibility, like I said, it does say static and active stretches. We don't do dynamic because dynamic often involves like a lot of momentum. So like if I'm doing arm swings, for instance, I might cause blood to pool in my hands. You guys have probably felt that before if you've ever been doing arm swings. And then like it feels like your fingers are kind of puffy afterwards. That's the kind of thing that we're being a little cautious with. So we're really just doing like level 1 and level 2 stretches. And even then, you guys heard me say, I don't personally like static stretches for my clients with hypertension. So I only do level 2. I only do the active stretches personally. Resistance training, 1 to 3 sets of 10 to 20 reps, right? We're going for a little bit more endurance there. 2 to 3 days per week. And we aren't doing any of the pausing tempo. This middle number should never be longer than a 1. It can be a 0 or an X, but we want to keep it relatively short. And then in special considerations, avoid that heavy lifting, don't let them over grip, and then modify your tempo if you need to. All right. Any questions on hypertension?
I'm good.
Love that. All right, fellas. Let's take a look. There we go. I love the thumbs up. I really do. I think it's a great way for me to like see how, you know, checking in and you're like, nope. Yeah, like it's great. It's easy. Brain. So I was like, where are we? Next thing we've got is coronary heart disease, or coronary artery disease is what you'll sometimes call it. But it's a disease of the coronary arteries. Your coronary arteries are, like I said, they're the ones that sort of loop right around the heart, right? So they come off this tube here and circle right back around, and that's sort of a limited version of them. You know, you'll see other pictures where there's sort of more detail than that, but that's what they are, right? So the arteries, and I haven't really talked too much about the difference between arteries and veins with you guys, just because it's not part of kinesiology. But arteries are sending blood away from the heart, and veins are sending blood back towards the heart. So you have coronary arteries, which are being ejected from the heart. They just loop right back around to supply the outside tissue of the heart with oxygen, just like any other tissue. And then you have coronary veins, which gather up the deoxygenated stuff to send it back to the chambers so they can get pumped over to the lungs. So clients who have had coronary artery disease will often have what is known as angina, which is chest pain. Okay, so if it'll feel like someone's sitting on their chest, or it'll feel like a pain that kind of runs along their chest. That is a warning sign that the heart is not getting oxygen, right? I equate it to if you've ever like wrapped a rubber band around your finger and left it on there for too long, and it feels like your freaking finger's gonna explode, and you're like, God, that hurts, right? That's what I equate angina to. It's definitely not that, but that is the from all the ways I've heard that pain described, it is very similar. That's what I picture in my head. So angina is another name for chest pain, and then coronary heart disease is commonly associated with all of these other diseases, right? Diabetes, sugar in the blood, making it hard to deliver oxygen. Obesity, excessive abdominal fat in particular, that is like affecting physiologic symptoms and affecting heart blood flow. Hypertension, which is preventing blood from being delivered where it needs to go. That could be your heart, which is going to cause the cells to suffocate a little and they're going to hurt, right? And peripheral vascular disease, which is known as PAD. That's what we're going to be looking at the end of today's lesson. That is where, in the same way that like you are sort of pooling blood in one area, this is where it basically pools in your legs, and it's very, very, very painful. That is very much like wrapping a rubber band around your finger, and you get that really bad pain. So, coronary heart disease is a very tough condition to deal with. If you have a client who has come back from a heart attack, it's there. Some people will bounce back no problem. Other people, it can be really detrimental. And so everybody is going to be sort of a little bit different here, but the nature of that disease is going to be based on, sort of what their own capacity is. So because of that, we need to be aware of what their limitations are. We need to continually keep an eye on them. The status of their heart can change super rapidly. They could be fine one moment and then they're ready to pass out the next. So if you have a client with coronary artery disease who has come back from like a heart attack or something, I always encourage trainers to get them an actual heart rate monitor rather than just like, basing it on like measuring it every few minutes or something like that. Having that continuous monitoring is very, very helpful. So continually monitor their pulse rate, and make sure that you work to stay, above the limit to make sure they're working hard enough, but more importantly, stay below the upper limit that keeps them safe, right? And that is something their doctor will probably prescribe to them. But basically, I usually tell people to think of it as about 50% heart rate max, which is even below zone 1. And then always screen for comorbidities because, hey, guess what? They have a lot of other diseases, like we just said. One thing to be aware of, like I said, their status can change super rapidly. They may be feeling fine 1 minute, and then they are dealing with chest pain or nausea sometimes, all kinds of problems. Nausea is sort of just like a interesting response when you're having like heart failure. Sometimes like people will describe it as it feels like heartburn, which is like a digestive system thing, right? But that's what it'll kind of feel like, and then that causes like a lot of nausea and stuff. It's just, your body is dysfunctional, and so it's like sending out all kinds of signals to get you to sort of help it out, So we got to be aware of that and be very careful there. With that, we are probably going to work out at much lower intensities, which may result in longer exercise sessions because we may be giving our client very extended periods of break, and things like that. Also, we want to make sure that we are not amping the heart rate up too quickly or slamming it back down into the ground too quickly. So our warm up and our cool down should be prolonged with clients who have had heart failure. Rather than just being like, all right, that was your 5 minutes. Let's hit the gym floor, right? We're probably going to spend 10, maybe even upwards of 15 minutes easing them into exercise and teasing the heart rate up so that we don't change its status too quickly. And the same thing is true about leaving exercise as well. When you don't cool down, your body thinks that you won the fight, which is great that you won the fight, but it does mean that you were in a fight, and that is something that your body gets stressed out about. So this is one of the reasons why it's so important for us to cool down. When you cool down, you are signaling that like, hey, the world is back to normal. We can relax, we can recover, we're fine. It's the biggest thing that people love to skip, and it's, actually quite important. So we really do like our cool downs. So both those may be prolonged, especially in clients who have heart diseases. Use the RPE method, guys, instead of training zones. Their heart is going to be damaged. So using a heart rate training zone like 65%, 75%, things like that, it doesn't really make any sense because those zones have now been completely fluctuated due to their disease, right? So instead, we're just going to check in with the client regularly. We love the RPE method, right? If I said, hey, Eddie, how you feeling about that set, right? Or, hey, Mir, how's the heart feeling, right? Like, do you feel like you get a lot of endurance? Like, what's going on? Thomas, on a scale of 1 to 10, where's your heart rate right now? Checking in continually, verbally, and just like keeping an eye on your client is going to be really important. Pair that with the fact that they might be wearing like a heart rate monitor regularly. And now suddenly like you're doing a really good job of, exercising, which is slightly dangerous, but it's like one of those things where it's like you're taking so many precautions, you're being cautious, you're being careful, and you're going to, your client's not going to have any problems. And then again, avoid isometrics. So same thing with our hypertensive clients. We don't want blood to pool anywhere. So again, large muscle group activities, stationary cycling, treadmill walking, rowing, all those things are great for a client who's coming back. Frequency, we're going to drop this down and say at least 3 days per week. Now, if they are very recovered, if their heart attack was minor, depending on the client, you may go 5, 6, 7 days a week, right? But ideally, we're saying, the minimum is at least 3 days a week. I know that's very vague compared to the frequencies we've seen in other versions, but it has to be vague because, again, coronary heart disease is like, there's such a wide array. Like my mom had a pretty minor heart attack. For the most part, she kind of bounced back from it pretty quickly, actually, which is great. But like, she is, she definitely needed like her recovery time. But like, yeah, those are definitely some, there's a wide array there. Some people it'll be very severe and they're going to need months of recovery. So intensity is anywhere from 40 up to 85% of heart rate reserve. Again, the Tug Test is very appropriate. The RPE method is going to be much more appropriate rather than this massive, huge freaking range right here. Duration may be 5 to 10 minutes of warming up, followed by 20 to 40 minutes of exercise, followed by 5 to 10 minutes of cooling down. I really like a good 10-minute warm up and a 10-minute cool down. If we're going for a full like 40, 60-minute session, that still leaves me 40 minutes in the gym, which is just fine. So that is sort of what that's going to look like. Movement assessments pretty much the same: push, pull, overhead squat, single leg balance. It's all fine. These aren't postural distortions, so like those assessments are all appropriate. Static and active in a standing or seated position. Again, we're trying not to like lay a client like this down because that's going to affect their blood flow. So if that's the case, we're going to try to, for the most part, keep them upright so they can do their stretches. Just probably do them either standing or do them seated in a chair. If they're going to stretch their hamstrings, for instance, right? This is my least favorite hamstring stretch, but it's definitely safe. I'm not going to, if my client, has blood flow problems, they're not going to pass out. Or if they do pass out, they're in a chair, right? So that is definitely my least favorite hamstring stretch, but it is the one that is most appropriate if I've got a client who is coming back from a heart attack. 1 to 3 sets, 10 to 20 repetitions, 2 to 3 days per week, identical to hypertension, right? So nothing fancy there. Again, don't forget, guys, these tables, I know there's a lot of rules on these tables. You don't have to have these memorized. What we're trying to do in this course is teach you how to look them up easily. It's not like you're going to get a client and then they're going to be like, oh, I never told you I have coronary heart disease. You will have found that out in the fitness assessment, and then you'll go home to write the routine, open your book, crack the table open, make some adjustments, and bring that routine back into work, and then train them on, the next day. And again, be aware that if they have had coronary artery disease, they probably are dealing with some other type of comorbidity, right? Diabetes, hypertension, etc. So if that's the case, just make sure you're being cautious there. And then lastly, modify your tempo to avoid any isometrics or a really long concentric action. Long eccentric is fine. Long lengthening of the muscles, that's fine. But long shortening or long like stabilizing, those are things we're avoiding. When you're like lifting and it's real heavy and you're just like finally finishing out that last final rep and it's real slow, we don't like that. We don't like that with hypertensive or coronary heart disease clients. All right, any questions there? How you guys feeling?
Pretty good.
Cool. All right, last one. Love it. So last one we've got PAD, peripheral arterial disease. If you want to be all fancy about it, we're going to call it intermittent claudication, which is basically blood clots. So that's not great. So for clients who have PAD, things to be aware of, like what this is it is pain in the lower extremities associated with limited arterial blood flow. So basically, you have limited blood flow to the legs, and in the same way that we had a heart attack because we didn't get enough oxygen, well, the muscles in your legs start to hurt because they can't function the way they're supposed to. Your leg muscles are suffocating, right? So the lower legs are not receiving blood flow from the arteries due to blood pressure issues, or sometimes it's due to plaque building up in the legs, right? This can cause clotting, which makes the problem even worse, which can be really dangerous, by the way. If you dislodge that clot and then it moves through your blood vessels and then gets up to your heart and then clogs one of your arteries, you just had a heart attack that way, right? Or if it gets to your brain, you're going to have a stroke. So we definitely do not like blood clots. And this is definitely something we are trying to fix in our clients by working those blood, working those blood vessels, right? Let's move that blood around to keep that clotting from happening. PAD is extremely painful, by the way. Like I said, it feels like when you wrap a rubber band around a body part, and then it just feels like that darn thing is like gonna explode or suffocate. It hurts. That is totally what PAD feels like, only it's in your entire freaking legs. So it is supposed to be very, 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 very painful. But exercise has a really positive effect. In fact, actually, let me look at PAD. Just so we can get a couple pictures here. So like I said, it is, you can see like plaque is building up on these blood vessels, so they'll get pain in certain areas. If you look it up on Google, the image they always pick is just somebody who's like, oh, my leg, right? A lot of times these are people who will need very frequent breaks during their workouts. Their legs are going to start to hurt, and they need to sit down for a minute, let that blood get out of the legs for a second, and then keep working after that. But I'm getting ahead of myself a little bit. So positive effects, things that are great about exercise. One of them is increased leg blood flow. That's awesome, right? Like that is immediately fixing the problem because again, blood vessel reps, right? It also improves your blood's cellular deliveries. One of the things we haven't talked too much about so far today is that one of the positive effects of exercise is that you will actually make red blood cells that have higher hemoglobin levels. Hemoglobin is a protein that carries oxygen. You'll have more iron in your blood to sort of constitute that. Your blood will have more enzymes in it, which make the chemical reactions that move oxygen around more effective, right? Those are some really great effects of exercise. And those are just in your blood cells, which are like these little things floating around in our body, aside from increased muscle mass, aside from increased neurologic capacity, just get better blood, that's awesome. So that is, the body becomes more efficient in utilizing oxygen because it increases its cellular deliveries. It also improves your walking economy. So you think about like how much effort it takes to walk when you are, have plenty of muscle mass and neurologically are strong and stuff. That improves the economy, which means like, if you guys have ever run like a 5K or a race or something, by the end of it, you're kind of exhausted, right? Start to do that kind of run where you start to collapse over. You're doing like this thing. You see those guys at the end of a marathon, they're like, just give me to the finish. They're just like trying to survive, right? That's not great, right? That's pretty bad, what we call oxygen uptake kinetics. You're screwing up your diaphragm and your rib cage's ability to drive oxygen. When you improve someone's walking economy, it's easier for them to stay upright. It's easier for them to be strong while they're walking, which is only going to make it easier to get oxygen into the blood cells, which is only going to make it feel better in the legs when they're delivering that oxygen. So it's a very roundabout thing. When you think about PAD, you don't think about posture. You think about like, oh, it's a blood vessel problem. Yes, but make the blood better, make the posture better to work with the blood, and the pain goes away, not to mention all the actually fixing the plaque and stuff. And we are going to see less reliance on anaerobic metabolism. Their bodies will actually get better at that oxidative aerobic metabolism. Now, physiologic differences for people who have PAD. Things to be aware of. One thing, smoking makes PAD way worse. Very commonly associated with smokers. Remember, smoking is allowing chemicals to pass into your bloodstream directly. Blood does like to pool in our legs. It's a gravity thing. Like where's water going to go? It's going to go to the bottom, right? Same thing with blood. It tends to pool in our legs. So we need to have blood vessels strong enough to get that blood out of the legs. And if it doesn't, then it just pools down there and it gets very, very, very painful. That's why you need to give clients with PAD frequent breaks. When I train a client with PAD, I keep 2 chairs with me, literally through the whole session. It's very weird, but it is something that I do. I will be like, all right, we're going over here. And then I grab the 2 chairs and I bring them with me. I set them down. And that way they have 1 chair that they can sit in and another chair they can get their legs up. And that helps that blood drain out of the legs. It makes it way, way, way easier. So that's not on here, but that is a recommendation I would give you guys through the years of experience that I have dealing with all these freaking coronary problems.
Crazy.
Resistance training. So PAD is frequently associated with diabetes and coronary heart disease. Again, sugar in the blood, or just a weak heart. Resistance training does have a really positive effect on this, not only because it works on your posture, which makes it easier to drive oxygen in, but also it strengthens everything around, your blood vessels. One of the things that's very interesting here, I want to pivot just for a second and talk about varicose veins. So peripheral arterial disease is blood pooling in the arteries of the legs. Varicose veins is blood pooling in the veins. So it's like maybe blood got delivered just fine, but then it didn't get sucked out of the legs effectively enough, right? That's what varicose veins are. So what ends up happening is, the veins get all stretched out. They literally get like pooled, right? Wow.
That's scary.
Yeah. Substantial. Good Lord. So now it's like blood is, because your veins look different. Your veins are very, very different. Number one, your arteries are much bigger. Arteries are way larger. That's why PAD is so painful, actually. Varicose veins are painful too, but like PAD is like really painful. But one special structure that you'll see in a vein that you don't see in an artery, take a look here. See how there's these little valves here that kind of open up? The pressure is really high coming out of the heart, right? Systolic pressure is like 120, and then it's over 80, which is the relaxation of the heart. That's the heart sucking blood back in, right? Well, it makes a lot of sense that like when something squeezes, it ejects the blood away. That's pretty easy to get blood to where it's going. But in order for blood to get back, your heart has to like suck hard enough to, and it has to be pushed through hard enough, right? So the pressure in veins is way, way, way lower. And that is actually why veins have valves in them that arteries don't have. These little valves prevent blood from backflowing. So blood gets ejected this way, and then the heart relaxes, the heart stops relaxing and then beats again, right? So then like blood moves and then it stops, but it doesn't backflow because it hits the valve. And then it opens up again, and then it moves up, and then it doesn't backflow. And then eventually it gets close enough to the heart that it's going to get sucked right in, right? So here's why I'm talking about this right now, and why strength training is so good at fixing PAD, and why it's so good with like varicose veins as well. If you look at your these little veins that run, your veins are actually organized to be somewhat near your muscles. And well, that'll work, I guess. There's a picture on the internet that I remember seeing. I just can't remember where the damn thing is. That's not it. So your veins are actually arranged to be situated between certain muscles. So when you look at your gastrocnemius, for instance, when you look at that calf muscle, remember how we've got two separate fibers, right? We got the side on one side and the side. So when they squeeze, it actually squeezes blood back to your heart for you. This is part of the reason why people pass out. If you've ever seen somebody like who at like a graduation or like a ceremony, and they're standing there really rigid, and then all of a sudden they just like, it's like faint. Have you ever seen videos of that on like fail videos on the internet? That is because they locked their legs, so they were no longer contracting any of the muscles, so blood started pooling, and then the brain was like, I need oxygen, that's it, lay down. Like when you squeeze your muscles, it actually sends some blood back towards the heart. So that's a special thing about veins. And one of the reasons why resistance training may improve physical function. And then one other thing to be aware of, if we talk about like all of this blood pooling, well, that means it's not going to be in the heart. It's not going to be in the lungs. It's not going to be in the brain. It's not going to be in the upper body, right? So PAD will often, people who are dealing with this will often suffer from decreased aerobic capacity and decreased endurance. all the blood's in their legs. They're having a hard time delivering oxygen around the body. So they have a decreased aerobic capacity. They have bad cardio as the result of blood pooling. And then that does cause like a lot of, like I said, aches and pains. Okay. So let's take a look here at the sort of special rules, right? We got treadmill walking, very, very preferred, stationary cycling, elliptical trainers, anything that's keeping them kind of upright and allowing them to kind of move their legs and build their endurance and stuff. Frequency, we want about 3 to 5 days per week, working up to every day, very similar to hypertension. This is very similar to hypertension in terms of how we treat it, but it's a little more painful than hypertension. So you will notice that intensity, we are simply going to establish an upper heart rate limit. So the way you like to do this is do what's called a VT test. And it's where you put your client on the treadmill, bring yourself a little journal so you can write in it and be like, all right, how's a 4.0 on the treadmill? How's that feel? And they're like, this is fine. All right, great, 4.5. And you're going to kind of gauge it and you're going to come up with zones that are particular to your client, upper and lower limits. Work your way up to 20 to 30 minutes. The duration's very short. Again, it hurts. They just can't be on their feet that long. They need frequent rests, frequent breaks. Assessments, totally normal for the most part when it comes to posture stuff. Flexibility, we like static and active. We're avoiding dynamic because, again, dynamic might cause the blood to pool in certain areas. Butt kickers are not so good. Leg swings are about as bad as it gets, resistance training, 1 to 3 sets. We are dropping the reps down to 8 to 12. Again, if you have them doing 20 reps, blood's just got all this time in the world to like pool in the legs. It's going to get painful. In 2 to 3 days per week. And in special considerations, progress very slowly and give them plenty of rest between exercises. They are going to be very inefficient workouts in terms of like how much you're able to get done. But eventually the pain starts to improve and you will eventually be able to like improve their capacity and you can do more and more and more as you kind of go along. All right. Any questions about any of those before we take a look at a SOAP example?
No.
All three of you guys feeling good?
Yeah, feel fine.
Love that. All right, there it is. We got the Simpsons hands. All right, let's take a look at our SOAP notes here. So this is our client, Mike. He is recovering from a heart attack that he had about 6 months ago. He has been cleared by his doctor at this point to begin exercising again. He is also dealing with a little bit of PAD problems and hypertension. So his hobbies are things like playing cards, bingo, going for a walk. So this guy is, objective information, he's 70 years old, right? He's an older dude. He's retired. Because of that, he's generally pretty sedentary. He is on a beta blocker, which is going to lower his heart rate and lower his blood pressure, which means we got to be cautious about using heart rate zones. That's probably not going to be our best option. And he does have constant pain in the legs, which is way worse when he stands on his feet for too long. So blood pressure is 140/90. Resting heart rate's about 85 beats per minute. Body fat percentage of 25. That's pretty high. Not super high, but it's not great. We had him do what's called the Tug Test. This is actually a performance agility assessment. I'm going to teach you guys this in the next course, but the Tug Test is basically it's the timed up and go assessment. And it's usually used on senior clients. It's really simple. You are going to have a client sit in a chair, and then you're going to have a mark on the floor or a cone, and that client will then get out of that chair. If he ever gets out of the chair. And then walks around the cone and then walks back and sits back down. And that's the whole assessment. So it took that guy who is clearly able to probably move much faster than that. It took him about 11 seconds, right? Our boy, Mike, it took 15.2 seconds. So he is not speedy. He is not the fastest guy in the world, but that is something that we can look for improvements on, We saw his knees turn out, actually. We saw knees caving out, which is pretty rare. We don't see that quite as often. We did see shoulder rounding, forward head posture, and elevated shoulder. So a lot of upper body dysfunction. His assessments, we decided to do the chair sit to stand assessment rather than the overhead squat because he can't really squat very well. So we decided to use a chair instead, which will be a little bit more gentle. But then the cable pushing and pulling assessment was just fine. That's something he can be on his feet. You know, we can lower the weight down. It'll be just fine. And then we really like that tug test. So we're going to use the continually check in with him using the talk test and the RPE method rather than assigning a specific heart rate percentage because he is on a medication. And also because, you know, we are really just going to need to establish upper and lower zones. We will always warm him up for a minimum of 10 minutes and cool him down for a minimum of 10 minutes. We want that to be relatively extended. We're going to avoid any isometrics. Which means we're going to do active isolated stretches for about 1 to 2 sets per exercise, 5 to 10 reps per exercise. And he is only going to hold for 1 second. So, you know, if he's doing his traps, for instance, 1, 2, 1, 2, rather than a big long hold. And then the muscles we're focused on are the upper traps, the pecs, the lats. And then we get into the lower body. We see the TFL. We're going to do a standing glute stretch and a piriformis chair stretch. So those are, just to fill you guys in, something like this, where he's going to push his knee away. That's the piriformis stretch. And then the standing glute stretch, you can use this for balance, drop his leg back here and kind of sit into this hip. And that's actually going to help with a client who, it's rare, but the bow-legged, right? The knees cave out. Cardiovascular training, we want him walking at least 3 times a day, every day for about 10 minutes each. That way we can slowly build up his endurance and improve that walking economy. But we keep it relatively short so he doesn't get too much pain in his legs. We don't want this 70-year-old guy going out for a 30-minute walk, get a bunch of pain in his legs, have nowhere to sit, and he can't get back home. Right. So we're just going to encourage him to take a short, brief 10-minute walk, maybe around his block and back, you know, a couple times a day. Resistance training twice a week, Tuesdays and Thursdays. We are going to keep the reps relatively low, even though it would be great to give to build up his endurance. But again, that PAD, that coronary artery disease, you know, we're trying to be pretty gentle here. So 3 sets, 10 repetitions, medium to slow tempo, 60 seconds rest. And we are not quite going to do peripheral heart action, but we're going to do something close to it, which is a superset method where we are going to pair, because he can't really handle a circuit, right? The circuit training is going to be a little bit too much, but we're going to get close to PAD. I'm sorry, PHA, peripheral heart action, right? Upper body, lower body, upper body, lower body, upper body, lower body is so good for blood vessels. So we're doing sort of a modified version of that. He's going to alternate supersets, but he is going to take rest. So he's going to do exercise A, then he's going to rest. Then he'll go do exercise B, and then he's going to rest. A, rest, etc. And A will be upper body, B will be lower body. And so we will get a little bit of that benefit without pushing him too hard. Does that make sense, guys? Oh,
Yes, sir.
cool. Love it. Well, that was another 90-minute one. This class there's just not as much stuff in it. But it's good. It's good that we're taking our time, you know? We get to be real familiar with these things. And it's the only time we ever cover this stuff, unfortunately. It doesn't really come back. I mean, we'll see it all show up in the senior class. So I guess it comes back like next week. But then we kind of move on and you won't see it again until capstone. So
Gotcha.
all right, fellas, let me kill the recording here and then